Oh, so we have the opposite. Can we flip the picture? Is it possible?
No.
So we can match it, exactly.
Oh, there's a right hand?
Yeah, this both the hand. I mean, it could be right or left, we don't know, but it's just that if you can flip the picture, one of the two pictures across, that will match it up because,
That's
and then we
true.
need to see a little bit of the radius and all area, which you don't see.
No, I don't have another one.
Can we can pull this up, can we?
Huh?
So we see, no, oh yeah, make it narrow. Oh, shoot, this, so we have to put this down here once you mark it up.
Yeah, you can hide it.
Oh, okay, good, so at least you can see. Anyway, this is flipped.
Actually, you can do this though.
Oh, yeah, way better. Good, I learned something there. Is there any way we can flip this around? I don't know.
No.
No. Okay. Anyway, we'll just pretend it's the same side. So here again, you know, obviously,
So right.
we want to do name and date of the patient. The most important, of course, which side is most important too. It's missing here. So here again.
This is the right side. This is the right.
Okay. Wait, no, this is right. And that's left, as you can see. So anyway, if you follow the bones here, as we know, we don't call these fingers with numbers, which a lot of medical people do, which is wrong. In hand surgery, we call this a thumb, and we call this index, middle, ring, and little.
But this is digit 1, 2, 3.
No, we don't never do that.
Not anymore?
Don't ever do that digit stuff. Call it the thumb, index, middle, ring, little, because everybody has confusion. Some people want to call this number one, and
Yeah,
some
me
people
too.
call the thumb, and then they call this one, and they call this 2, 3, 4, 4 digits in a
Oh.
thumb. So it's confusing. So
It is
just use standard measures. You never go wrong. In medicine, you just want to keep with the old tradition. Sometimes it's always good. Remember, we have only, if you follow each bone, we only have 2 phalanges, okay? A proximal and a distal in the thumb. We got 3 in every other bone.
This is MIP.
So yeah, so we'll start with the bones first. So you got a proximal, a middle phalanx, and we got a distal phalanx. Okay, 3 in each finger, from the index, middle, ring, and little, and 2 in the thumb. We don't have a middle phalanx in the thumb. So anyway, then we go to the metacarpals. We got a short thumb metacarpal, and we got pretty much decreasing size. Actually, it's very interesting if you follow the lengths of the metacarpals for the hand as you go from the index to the little finger. It's a slope actually, so like a nice gentle slope. And this is important. If you have a fracture, this slope is adjusted, right? It'll be shortened, and then you see a defect. We try to gate the slope back on. Everything in human anatomy has a sort of a nice curve. If you follow the normal side too here, you have there's a pen here. You have a curve. So you have a nice curve, slope and curve. Nice curve. It's like a ski slope here in the radius. It's from the ski and you land up on the ulnar. If this curve is disrupted, something is wrong. So if the ulnar is running short, or actually the radius is running short and the ulnar is up, it's called Madelung's deformity. You can look it up, Madelung's. And it's a defect, and you get an ulnar minus or an ulnar plus, depending whether it's riding up or down, depending on the radius function. Also, all radius fractures will mess up this angle and the slope. So anyway, watch for the slope. Most of the time with the boxer fracture, when the fifth is abnormal,
Boxer
it'll always
fracture.
be down. This will be sitting here, and you know the slope is gone. Also, when you flex your fingers, all of them, flex them down because that's slope. All your fingers, if you draw lines to them, if you just draw a line through each of them.
No,
Sorry.
no, you have to
shoot.
use this one.
Oh, no, I'm like, yeah. So if you draw, let me go back up. This is very important when you see someone with a hand fracture. When you flex their fingers down, all of them should point towards the scaphoid here. They all should point towards the scaphoid bone. And if the fingers are not pointing, they're rotated, then we know that there's a fracture that needs reduction and surgery, because if the bones all are aligned, but they still point to the scaphoid. See, like this, you're good. When you flex the fingers, they should all point to the scaphoid. If they're like this or they're twisted, then the bone is rotated.
Wait, say it again?
Yeah, so when you flex your fingers, technically they all will actually point a little bit at an angle towards the scaphoid. And you just gently relax. They always point towards the scaphoid. But if it's if it's
To
rotated.
this bone right here.
Yeah, to the usually it's not exactly midline. They all sort of go at an angle. So it's like when you really relax it, when you're doing it like straight, but when you relax and put it in, they'll actually flex towards the scaphoid. They're not like this.
What is this left like this? Left like this?
Yeah, no. If you fold your
No,
hand.
no, no. This is image. Is it left?
Yeah, that's
Or
left.
like this?
No, it's actually this way. Yeah. So when you flex them, it'll all point towards the scaphoid bone. So here we again remember the acronym. We use a little mnemonic.
So this hand's like that, and it slopes down now. Okay?
Right, yeah, it's a slope. And when the slope is gone, you'll see where the knuckle is depressed. When you have an old fracture, if you follow the slope with the flexed hand, if they've had an old fracture, it'll be depressed like this. And you'll see that, then you know they're an old fracture. Just on clinically examining them, the knuckle won't have a nice slope.
Rheumatoid arthritis, and this is huge.
Yeah, so in rheumatoid, like we talked about, there's no spurs because the pannus eats up the cartilage, the pannus in the joints. So that's one. And plus they'll have the fingers will basically skew to one side, like that, it'll skew out. So, and as you remember, the last thing I'm going to go through is really the bones here. We use the little mnemonic, she looks too pretty, try to catch her, okay? So you start from the base, so scaphoid. That's good. So scaphoid, yes.
It's so hard because it's opposite. It's left. That's
Yeah,
left,
that's
right.
I'm just going. It's like so scaphoid. Oh, we use red.
Yeah, you need to make it darker.
Yeah. So let's use red. So scaphoid. It's like a peanut. Scaphoid,
She look.
lunate, triquetrum, and pisiform.
She
Okay.
looks too pretty.
Trapezium, yeah.
Try.
Trapezoid. Oh, sorry, trapezium is here. Trapezoid, capitate.
Try to
And
catch.
that's the hamate with the hook of the hamate.
Where's the hook?
Yeah, little thing. You see the white? That's
Mhm.
the hook.
There's the hook.
That can be broken a lot. On this side, it'll be the other way around.
She looks too pretty. Try to catch her.
Yeah, on this side. So it's really interrupting there together. The lunate and the trapezium
There's too
and
much.
pisiform is all on together.
There's very little joint space. It's
Yeah.
very dark calcium white.
So we got trapezium, trapezoid. This is capitate, and that's the hamate. That's the hook of the hamate. You see that?
Uh-huh.
And it's like that, the hamate. So we'll back that up. So you can see the hamate, the hook.
Mhm.
Okay. So here again, always look for basal arthritis, dislocations of the thumb, of the finger. So these
So
bones are
with
lined.
the rheumatoid, there won't be any bone cysts.
The bone cysts, there'll be
spurs.
bone cysts, but there won't be spurs because the cysts are actually made of acid, usually like hyaluronic acid and stuff. They're filled with that from the joint, so it eats up some of the bone too.
So rheumatoid arthritis won't have.
So
say
the
again?
ligaments, first of all, they'll have cysts, but they won't have spurs. They also, you'll see ligament injury, so the whole bones will be slid over, and then they shake hands. Their hands are like that, skewed.
Yeah, yep.
It's all skewed out to one side because all the ligaments are weak and torn.
What is this
inflamed.
right there?
So this is just an ossicle. It's just to make the tendon work better. It's like your kneecap. You got one here. You got one maybe at the tip too. So you can actually have some fractures of them sometimes. So anyway, that's just a lot. So you look at fractures. On the fracture, on the second metacarpal, it may be oblique fracture, but it looks like a line. But you always look for the height. If the height is short, and if you see on this view, the bone, to know if it's rotated, and it looks like say this bone is rotated, and it'll look like this. It looks smaller. This will be smaller than this width. Then you know it's rotated. Okay, if the width of this is smaller, or this is smaller than that, and now this is equal, so you know it's not rotated. The fracture is non-displaced. But if the width is small, either proximally or distally, then you know it's rotated. Okay.
But isn't this? Isn't this metacarpal?
Yeah, MCP joint, metacarpal
This
phalangeal
this
joint.
is proximal, and this is distal.
DIP, pip and dip.
Okay.
So this is pip, this is dip. Okay, interphalangeal, proximal, distal, and that's the MCP. And this is what, then you get the basal arthritis is the most common especially in women golfers, this arthritis, and we take this bone out here, the trapezium
Because I had
trapezoid.
that one patient, she does a lot of typing, so she
Yeah.
was pain in her thumb, and her X-ray showed that these two bones were
Yeah,
very
so-
calcified white.
Yeah,
They're
so most of the
making
time,
contact.
so I used to do a little procedure where, so you can actually take this whole trapezium out, and you take one of the tendons out here, and you rotate and put it in what's called an anchovy roll, like a fish roll, and you stick it in there. I used to just use a special implant made of graphite. It's like a ball bearing. I'd make a hole here and make a hole here, and I'd fit the ball bearing inside exactly tight, and so it'll rotate on a ball bearing. That's a really cool, very simple procedure, and didn't disrupt the anatomy. And it gives you a space now, it spaced it out. And if you made it properly, the ball wouldn't jump out. But if people made the ball too big, then the ball would want to fall out and dislocate. But if you make it just right and tight, the ball sits like that, and it's a really cool procedure. So
Real quick, one last thing. I want you
Mhm.
to explain to me the almost simplicity
yeah.
about trigger finger, the attachments, how it gets caught.
So
when they do
basically, on a
flexion.
trigger finger, so on a trigger finger, basically, if this is a fishing rod, and there's a line which is a flexor tendon. Say, imagine it's the flexor side running.
Mhm.
There are rings that hold the tendon to the bone. So we got pulleys called annular and cruciate. So annular around and cruciate are like a cross, cruciate. And we got them numbered. And this one here, just for simplicity, this pulley here around this MCP joint gets inflamed. So it's like a ring like that. So the tendon will actually flex through and form a little swelling here, and it gets caught in this tendon. So in the morning, it's swollen, it won't let it go back, so its finger's caught. And as soon as you try to pull it through, this big lump will push through and release it. And then it's hard to blend it again because this lump here of this tendon doesn't want to get through this tight pulley, the A1 pulley. So we need this pulley because we don't need this one, we can release this, but every other pulley we need, so we don't release the wrong one, because then the tendon
So the
falls
surgeon will
off.
go and just cut it.
So yeah, we just numb it up, and you cut one side of it. We don't I like to don't cut in the middle, I cut on the side. So we still have the pulley sitting on there, but it's not attached. If you cut in the middle, it opens it up, and I don't want the tendon to fall off. So it'll still be like acting like a pulley, but it really is not attached. So it's opened up, C is opened up now. So if you have a tight ring, if you cut one side, it opens up the ring. So normally you can inject in this area. You want to inject alongside the sleeve. You don't want to inject into the tendon, as we always talk about putting any steroid in there to help it. And that usually works really good. It's a trigger injection.
So you'll do an injection.
Yeah, so I inject
You do
into on the palmar
so-
aspect.
So majority of people have this is the one that's causing issue.
Yeah, it can be the ring, or usually.
So
it can be-
would you inject going this way with the needle or going that way with the needle?
So it's always go along the palm. It's easier. I would go like that. And if this is the pulley, I try to put it on the side of the pulley here. And there's a sheath, there's a flexor tendon sheath, and if you can get it on the side of the pulley here, and the palm aspect, you'll feel the pulley, and you'll feel the knot below that. That's where the tendon, if you flex it, you'll feel the tendon comes through. But the knot, if you pull it through, you'll feel the knot slide through. And the pulley is very tight and it's thick, and you inject inside the pulley.
Only do cortisone or regenerative medicine, never lidocaine, never.
No, you can put lidocaine.
You can?
I put lidocaine, marcaine all the time with steroid. Lido, marcaine, and steroid. If you do not have stem cells, if you have stem cells, just steroid and stem cells, or just stem cells. Okay, that's an option. But without just plain steroid, you want to put some lidocaine, marcaine because you hurt the patient. But you get nothing wrong with the anesthetic, and with steroids, you really want to use it. We use the most common injection is using the combination.
Because I had a patient, her thumb, she'd flex it,
Mhm.
whenever she'd do extend it,
Yeah,
it would
it's
like.
a trigger thumb. So this is the problem, the trigger thumb. Okay, here's
I felt
pulley.
it there.
Yeah, it's very interesting that you said that, because that's like shoulder problems. Usually if your rotator cuff is involved, you'll feel the upper arm pain. The tendon, because the tendon's attached up here, you'll feel the impulses and all the problems up here, but the pulley is the problem here. And if you press on this, you'll feel the nodule, and they'll reproduce their pain up here. But because the tendon runs its length, it's radiation of pain, and you'll see the clicking noise will happen up here, even though the pathology is up here. Isn't that interesting?
Because she'll flex it and then I'll feel it, she'll release, and it'll like roll.